The content discussed in this episode may be specific to the guest's organisation or location and may not be applicable to other organisations, states, territories or countries. The material presented in this podcast is for general information purposes only and should not be considered health, legal or financial advice. Medical administration is a rewarding profession, but it comes with challenges. So what is it like, and what should you do if confronted with a monumental administrative difficulty? This is the podcast that takes unfortunate scenarios and explores the essentials of clinical governance to find solutions. I'm Dr. David Rankin, a very experienced medical administrator and lead fellow with the Royal Australasian College of Medical Administrators. And this is Safeguarding Healthcare, the essentials of clinical governance. Today, a tragic end.
Everyone will be asking how a person who's in hospital was able to take his own life.
That's Dr. Nick O'Connor, Clinical Lead of the Mental Health Patient Safety Program at the New South Wales Clinical Excellence Commission. Nick is a psychiatrist with more than 25 years of experience in clinical leadership and assesses medical practitioners for the New South Wales Medical Council. And I'm presenting him with a difficult scenario.
This approach is not so much interested in who made an error, but how problems emerge from our systems and processes of care.
In this episode, Nick and I will discuss the restorative justice method. In today's scenario, a young man named Ed is admitted to a psychiatric inpatient unit for treatment of his second episode of persecutory delusions, auditory hallucinations, and depressed mood with suicidal ideas that are not responding to treatment. It's been a lengthy admission, and his parents have arranged to accompany him on brief leave off the ward each day when he's considered settled enough in the morning handover. The team has noted that Ed has been particularly distressed by his thoughts and has been talking about being better off dead. His day leave is cancelled and he is to be confined to the ward. But that afternoon, Ed requests permission to leave the ward and tells the nurse that he has been granted leave to meet his parents for a walk in the hospital grounds. The nurse is new to the unit and hasn't received any information about Ed's care from staff who attended the morning handover, and nothing has been entered into his progress notes. Soon, Ed is noted as absent from the unit, and at the evening meal, a phone call to his family determines that they have not been to visit him. That evening, the police inform the hospital that Ed has been found deceased in the local river. Nick O'Connor starts by explaining the primary challenges that this scenario raises.
Ed's death is a catastrophic event for his family. The loss of a loved one to suicide is just overwhelming. And so the family will have a range of needs that go beyond just care and support. The staff on shift, particularly the treating team and the nurse, will also be really distressed and experiencing a range of profound emotions. It's likely that the wider mental health service will also be experiencing some level of distress. Everyone, but particularly the family, will be asking how a person who's in hospital to ensure his safety was able to take his own life. This is a national central event, so the hospital executive are going to be really concerned and involved in the management. I think the challenges in this scenario include, of course, providing support and ensuring care is in place for the family first and foremost. Very important to provide support and care to staff, briefing the hospital executive, and then later reviewing the patient's care and trying to understand the sequence of events. And following that, from a restorative justice and learning perspective, ensuring support and healing as much as possible, involvement of the family and the staff in the development of system improvement recommendations.
In the scenario, there were so many holes, I guess, that lined up and ended in this result. And traditionally, we would explore those holes, try and identify what the processes were that allowed those holes to line up, and the failures, I guess, in the system to try and prevent that happening again. Today, we want to explore the alternative restorative justice process. Tell us how restorative justice is different to our traditional RCA review and identification of the holes and how that lined up.
Sure. So in relation to the death of a patient from suicide, like the scenario with Ed, the restorative just and learning approach is able to respond, I think, differently on a number of levels. Firstly, there's a deeper, longer, and more empathic engagement with the family that aims to, over time, to restore relationships and trust. It's a real exploration and meeting of their needs, and offers to involve them in contributing to the review and the systems improvement response following Ed's death. Secondly, there's a more structured and systematic support and care provided to staff, usually with immediate, on-the-spot, trained peer clinician support by the team leader and by other senior clinicians in the team. And in caring for both the family and the clinicians, in a restorative approach, we're very mindful not to compound the harms that they might be experiencing. Compounded harm occurs when we are not sufficiently attentive to the repairing of relationships and the human impacts that are always disrupted when there's a serious patient harm. Thirdly, and just going to the point that you're making, David, we bring a perspective that includes complex adaptive systems thinking and human factors thinking when we're reviewing and analysing a serious harm like a death from suicide. This approach is not so much interested in who made an error, but how problems emerge from our systems and processes of care on the day, and what can we do to give the clinicians working in the system a better chance to be providing safe and reliable care in the future. And then finally, it's a collective commitment to learn and improve. And this is why when I'm talking about restorative just culture in healthcare, we extend it to be restorative just and learning culture, because the learning and improvement aspects of this are so important in healthcare. So restorative just and learning culture brings this commitment from the organisation, from the team, from the clinicians to be forward-looking in their accountability rather than looking back, and for everybody to take an active responsibility to restore two things: well-being, and secondly, to learn and improve how we can make our systems of care more reliable and safe.
So at what point does the restorative justice process deviate, I guess, from our traditional approach? Do you still have a root cause analysis with an expert group reviewing the record and processes, and restorative justice comes in to bring the implicated parties together after that? Or does restorative justice change the whole process from the initial investigation?
So one of the things that restorative just and learning organisations would use, I think, less frequently would be a root cause analysis. Now, root cause analysis comes to us from, aviation, and I think is a very good method of reviewing things going wrong in controlled and predictable systems. And it still has its place in healthcare, there's no doubt about that. But in a case like Ed's death, a restorative just and learning culture would be thinking about applying a review and analysis framework that is much more attuned to capturing the complex adaptive systems and human factors involved in the processes of care. So that's one distinction. I think the level of involvement and engagement of both the family, when that's possible, and certainly of the clinicians involved in the care would be another distinction, I think, with restorative just and learning culture, which would see that the perspectives of those people who'd actually been involved on the day and leading up to it really have a lot to contribute to that type of complex adaptive system and human factors understanding of the processes.
My understanding is restorative justice sort of came out of South Africa after extraordinarily contentious friction between populations and the idea that you needed to be able to move on and forgive. Is that a correct understanding of where restorative justice came from?
Well, it actually has a longer sort of history and tradition than race and political relations in South Africa in the 20th century. It really does have roots in First Nations cultures and traditions, both in North America, but also in Maori and Aboriginal people. These are cultures that value the centrality of relationships and the vital interconnectedness of people. And in their worldview, important significant harms are a tear in the web of the relationships and a wound to the community, and that these things need to be healed and put right. Now, the restorative idea has been applied in international relations and in places like South Africa. It's also been applied in the corrections service, so in criminal justice settings, and is quite widespread in education, particularly school settings. Bringing this to healthcare is a reasonably recent development, and people like Sidney Dekker have been championing that. I might say, though, that in a paper that was written in 2005 by John Braithwaite and a couple of other colleagues, commissioned by the Australian Commission for Healthcare Safety and Quality, in that paper, Braithwaite and his colleagues recommend a restorative justice approach and a learning organisation approach way back in 2005. I think we have been slow in the uptake.
One of the challenges is, I guess, in many ways it's easy to do a root cause analysis, find out what went wrong, make recommendations about what you're going to do differently. Restorative justice takes perhaps more courage as leaders to establish a culture that's open to restorative justice and learning. Can you talk to us about the leadership that's required to run a restorative justice program?
Sure. And I think just to amplify your opening comments there, it does take a different approach to the root cause analysis approach, which I think its limitations are it tends to have a sort of linear cause and effect lens to harms, and it's prone to hindsight bias and also to counterfactual thinking. The move to a more complex adaptive systems and human factors approach is a courageous one in some respects, but it makes a lot of sense when you look at some of these more contemporary tools for analysing harm in healthcare, like, for example, the Systems Engineering Initiative in Patient Safety, the SEEPS tool, that does exactly that. It is more of an organisational commitment, however, because it does require leadership of a certain type. It requires establishing at the team level and at the organisational level psychological safety and a real elevation of the importance of relationships and trust. As I said, it requires a sort of more sophisticated understanding of the human impacts of medical harms and complex adaptive systems thinking, and then finally a commitment to improvement science. So restorative justice and learning culture is really a whole organisational, cultural commitment, whereas a root cause analysis is a method or a tool. So I think that they're sort of the differences. In terms of the leadership, it's moving to a leadership that understands that the organisation's people, the staff, are the ultimate source of the resilience and innovation in the delivery of healthcare. It understands that as a leader, one of the most important roles is to understand and do things that we need to support excellence at the front line of care, because that's where the rubber hits the road. And leaders who are prepared to be collective and share their leadership. So the leadership style is a collective and distributed through the organisation based on working together in trusting relationships around a common goal, which is safety for everybody. This sort of change is not programmatic. You can't sort of direct or specify this. It's relational and social. It's got to be sort of co-developed with staff, patients and families.
How do you respond to the criticism that if you don't find the perpetrator, you can't guarantee that the scenario won't happen again? I guess families and relatives in a situation like this want to know who didn't write in the notes, who didn't tell the staff that Ed wasn't allowed leave, who didn't follow through, so that you've got this sort of blame, accountability. Restorative justice is seen in some ways as being softer.
So I think it's a common and understandable human and societal reaction when something horrible and catastrophic like the death of a loved one to suicide or to a surgical mishap or whatever occurs, that, people and I think society, media often quickly jump to, I want to find out who's to blame. And the scenarios, I think, it's a very good scenario for this sort of discussion because on the face of it, the clinicians involved, as you've mentioned, might be the ones that the finger's pointed at. Restorative justice and learning culture starts from a different set of assumptions. It starts from assuming that we are all trained, educated and capable professionals who come to work each day wanting to do the best thing for our patients, and we also want to learn and improve as much as we can. And we know from the literature, and this has been found and reported for decades, that most of the things that are seriously wrong in the healthcare system are not due to, bad apples or people, intentionally or negligently doing the wrong thing. That there's a whole lot of complex reasons that the progress notes didn't get written in on that day, that the new nurse had not had a verbal handover from the morning team meeting, etc. And so trying to understand how that sort of happened and in what ways can we improve our systems and processes to give the staff on the day, every day, the best chance of actually providing reliable and safe care. That's the sort of difference. Now, it's not a soft option. In fact, it's not less intense in terms of resources. It's a real commitment to taking active responsibility to do the best we can to improve the systems of care.
Talk to us about the concept of psychological safety and compounded harm, which is often raised in our traditional investigation of adverse outcomes.
Yeah, look, psychological safety is really foundational to restorative justice and learning culture. It's the basis for trust. It's the basis for team and organisational cohesion and learning. And so we need, just as we've discovered in aviation, we need anybody who's got a concern to be feeling safe to ask a question, to raise a concern, to suggest a different way, and to feel safe to do so, to be able to be vulnerable by asking somebody who might be above them in the team's hierarchy, is this right? And so restorative justice and learning cultures measure and monitor psychological safety. And psychological safety is not just about everybody being nice to each other. It's really a sort of a maturing of group relations, and it's got to be sort of, workshopped and negotiated and maintained. Compound harm. So one of the things about restorative justice and learning culture is that it brings the lens of human impacts of medical harms much more into focus than I think our traditional analysis of medical errors and incidents. Compounded harm is when the human impacts and needs that inevitably arise from serious medical harm are sort of ignored or not addressed or in fact sort of exacerbated. And sometimes this can occur through our normal processes that are well-intentioned. For example, talking to the family, particularly in the early months, about the death of their son as being the incident. The root cause analysis method being applied to this case is going to make probably the treating consultant and also the nurse really feel that they're in the hot seat. So these are the ways that we can compound harm by not being mindful of the human impacts that are inevitably associated with these really serious medical harms.
Nick, I guess one of the concerns in a restorative justice process is that it might take a long time. Everybody's as we've discussed, upset about the process and the outcome, and to express their concern may take some time and quite extended engagement. So does restorative justice and learning require a commitment to a longer, more extended process?
Look, I think that often it does. And one of the things I think that's different about this approach is that it's hard to sort of specify and to contain in a clear set of guidelines with boundaries around it, how long it takes. And there's a concept in restorative justice that the timing has to be right to do some things. There's no doubt that this is a commitment to a deeper and longer engagement, particularly with the families. It's also a structural and cultural change in terms of how we support our staff. So that requires some investment. For example, in the places where this has been done, it requires identifying a team of clinicians, giving them some training in responding to their peers when they're distressed and affected by such incidents, and then maintaining that roster, etc. But it's been done very successfully in a number of places, and it really makes a difference to staff perception of their organisation's level of support.
I guess that was my question, is does it work? Do you have examples where it's been implemented successfully?
Yes. Look, the two, I think, best examples and the ones that have got some published papers about their journeys implementing this type of restorative justice learning culture are the Merseyside National Health Service Foundational Trust in Liverpool in the UK. Just by coincidence, that happens to be a mental health trust, but it's a big organisation, and they have published a paper that describes their journey and also the economic benefits of going down that track. And the second one is in Queensland, and it's the Gold Coast Mental Health Services and Special Services. And both of those papers I can provide as reference for these podcasts. I think the thing that they've shown is that it's not easier than our current approaches. It's not less resource intensive. It's a different way of directing our current resources and doing the work that we already do. But what both these organisations have shown is that for staff, patients and families, they are generally more satisfied and they feel more supported and engaged.
You suggested at the beginning that restorative justice and learning culture probably isn't applicable to all serious incidents, that it's more applicable to some than others. Where do you think it would be most effectively targeted?
In these organisations that have implemented it, they have an executive team that looks at all harm incidents every week, and they triage them in relation to what sort of response is required. This is early days, I think, for Australia and for the New South Wales health system, which is where I work. But we think that deaths due to suicide that occur in the community, which unfortunately are, too frequent, and probably one of the most frequent serious adverse event in mental health services, we think that is probably a good place to start. Whether in Ed's case, for example, the executive might think, well, because this is a national central event, we don't want to go down that path at the moment. We need an external review and, we're committed by legislation to the root cause analysis. And so it's a really judgment decision where you make this type of investment. But I think the message also is that restorative justice and learning culture, there's stuff that you can do right now and every day that isn't at the sharp end of, the serious medical harm like the loss of a patient to suicide. It's about building the social and cultural capital that supports these types of elements through everything that we do.
I think that's a really important point, that it's not an either-or process. That if you've got legislation that requires you to do a root cause analysis and report back to the department within 60 days or whatever the limits are, that's fine. But you can add a restorative justice element to the resolution at your facility.
Absolutely.
Lastly, Nick, what's your vision for restorative justice in the future? Where would you like to see it ending up?
Look, I think we are in Australia in the early days. I think there are a number of services in New South Wales and Queensland that are moving to develop and mature their safety culture to incorporate restorative justice and learning approaches. New Zealand is much more advanced. They have this year revised their national incident management policy to incorporate the restorative framework. And they've also taken a multi-agency approach, including health, social care and justice systems. Look, I think this type of organisational change can't be taught didactically or copied out of a book or pasted into from one organisation to another. It really is a relational journey for each organisation who makes their commitment to a journey of transformation. I think we're in the early days, and I think we're all going to learn and develop and iterate that learning and understanding as we go.
That was Dr. Nick O'Connor, speaking about restorative justice. That brings us to the end of this episode of Safeguarding Healthcare. I'm Dr. David Rankin. Follow Safeguarding Healthcare free on Apple Podcasts, Google Podcasts, Spotify, or wherever you listen to podcasts. This podcast is produced by Sound Cartel for the Royal Australasian College of Medical Administrators.